Good day, ladies and gentlemen. My name is Tasha, and I would like to discuss the link between diabetes and heart failure, one of the lesser known macrovascular complications. The first question we have to ask is how common is heart failure in diabetes? In female diabetics, they have a 5 times higher risk, and male diabetics a 2 times higher risk when compared to their non-diabetic equivalents. The prevalence of heart failure in diabetes ranges between 9 and 22%, and the presence of diabetes in patients with heart failure between 10 and 47%. If a patient has both heart failure and diabetes, this increases their mortality by 37%. In diabetic trials, hospitalization due to heart failure is used as an endpoint of cardiovascular safety. Diabetics have a 33% higher risk of being hospitalized for heart failure. One might not expect this, but the presence of heart failure is an independent risk factor for the development of diabetes. Our second question is which diabetics are at risk of developing heart failure. Older age, hypertension, obesity, and a longer duration of diabetes is associated with a higher risk of heart failure. Furthermore, the presence of comorbidities such as coronary artery disease, renal, eye, and vascular complications also contributes to this risk. Poor diabetes control, with every 1% increase in HbA1c causing an 8 to 38% increased risk. The way diabetes causes heart failure is thought to be via 2 mechanisms. The first is related to ischemic cardiomyopathy, that is a complication of coronary artery disease, and the second is thought to be due to diabetic cardiomyopathy, a concept that originates from 1972, where thickening of the heart muscle, fibrosis, and dysfunction of the autonomic nervous system caused heart failure. The presence of heart failure influences the way we treat diabetics, and is a complex interplay between the functional status of the patient, their capacity to look after themselves, and the availability of social support structures. The medication side effects, cost, and risk of hypoglycemia, together with the treatment burden to the patient, will further decide on the choice of diabetes treatment we use. The treatment goals in patients with both diabetes and heart failure should be individualized. There is no one correct HbA1c for diabetics with heart failure. A U-shaped curve illustrates the relationship between mortality and HbA1c, and while a lower HbA1c might seem ideal for all patients, in high-risk patients it caused an increased mortality. In younger patients with a long life expectancy, we aim for a lower HbA1c, while in older patients, those with comorbidities, and those with a shorter life expectancy, a higher HbA1c is tolerated. Amongst the conventional treatments, metformin remains the first line unless there is a contraindication, but it should be stopped in case of decompensated heart failure, especially in the presence of cardiogenic shock due to a buildup of lactic acid. Sulfonylureas, insulin, glitazones, and the DPP-4 saxagliptin has been associated with an increased risk of heart failure or hospitalization for heart failure. And in the presence of other preferred treatments, the risks versus benefits should be weighed up for each patient if there is no alternative available. The place of GLP-1 agonists in patients with heart failure is complicated by cost, adverse events, and being an injectable drug. They do not have any benefit in preventing heart failure in at-risk patients. They are generally considered safe, but caution should be taken in patients with established heart failure, especially with recent decompensation. There is, however, a new kid on the block. A new class of medication, known as SGLT2 inhibitors, has recently been introduced in the South African market and includes empagliflozin and dapagliflozin. These drugs are proven to reduce the risk of hospitalization for heart failure between 27 and 35% in the different cardiovascular outcome trials. In a recent groundbreaking DAPA-HF trial, dapagliflozin was given to patients with established heart failure and an ejection fraction of less than 40%. 45% of these patients were diabetics. The results showed a 26% reduction in the combination of hospitalization for heart failure, death from any cardiovascular cause, and death from any cause. This was largely driven by the 30% reduction in risk for hospitalization due to heart failure. Patients that benefited most had mild heart failure, and a significant improvement in symptom scores was seen at 8 months. Dapagliflozin was equally effective in diabetics as non-diabetics. We need to treat 21 patients, diabetics or not, with established heart failure and a reduced ejection fraction to prevent one hospitalization for heart failure or death. What about choosing heart failure medication in diabetics? Some medications used to treat heart failure have additional benefits in diabetics, including renin-angiotensin-aldosterone system inhibitors, the combination of angiotensin receptor neprilysin inhibitors, and carvedilol. Spironolactone had a negative effect with a 0.16% increase in HbA1c, but this is not a class effect. The take-home message for today is that having diabetes increases your risk of having heart failure, and having heart failure increases your risk of having diabetes. Preventing complications and optimizing treatment for both diabetes and heart failure can modify these risks. Thank you for your attention.